but your computer.
Testing.
Oh, I have to re-up this.
Yeah, so we're on. Just so you know.
Your
Why is this happening?
computer is muted, right?
Yeah, so I would. Two? Okay. Oh, I see. Test.
Okay.
Yeah, we're good.
Whether it's good for the person that's
It
recording.
should be, because that's mic is on and that's connected.
Oh,
to
good.
everything.
Okay.
Well, this will remind me of doing the morning news.
Oh,
studio.
yeah.
By the way, I think people could potentially be logged in right now.
You
So-
should see
oh,
the
we do have,
numbers.
we have 5 participants.
Great.
Yeah. Okay.
And they should be hearing us.
I think they hear us.
Your colleague, whoever is monitoring this, could also send messages in the chat to you, like if they weren't able to.
Testing. We're going to start in just a couple of minutes. Okay, thank you. So we don't have a proper sign-in sheet, but we would like to get your names and contact. So if you could just put it on the back of this paper, we'll pass that around. So I'm not going to do introduction of you. I could mention a little bit about products and sale.
I'll just do a one-liner.
Yes, it's going to be on the screen too.
Yeah.
Close the doors.
I kind of would lean towards keeping them open just so people feel like they're have an easier time coming in.
Maybe that one.
Should I shut that
Yeah.
far one?
No, I Well, thank you for joining us for the side event. The side event is sponsored by Physicians for Responsible Opioid Prescribing. That's an organization, an NGO based in the United States that has been working on the opioid crisis. In particular, we've been focused on promoting more cautious prescribing practices, and we've been focused on advocating for better regulation of opioid manufacturers, in particular, the way in which they market opioids in the United States. I'm joined today by Dr. Caleb Alexander and Bridget Brennan. Dr. Alexander is an expert in pharmacoepidemiology, and he's also a physician who treats patients and practices as an internist. Bridget Brennan leads New York City's Special Narcotics Prosecutor's Office. And I think it's not just important symbolically that we have really leaders here, both in law enforcement and in public health. I think it's an important message to send, because too often, and we see this both in the NGO community, but also in member states, what seems to be an argument between whether or not the response to drug problems should be focused on supply control or law enforcement approaches versus demand reduction or public health approaches. And I think you'll understand after this talk the importance of really addressing drug problems, both with law enforcement and with a public health approach. So I think we will get started with that. First, we're going to hear from Dr. Alexander.
Thank you, and good morning, and thanks for coming early in the day and starting your day with us. As you've heard, I'm a practicing internist. I perform general medicine for adults, and I'm also a pharmacoepidemiologist. So my work focuses on the use and the safety and the effectiveness of prescription medicines in large populations. I have served as a paid expert for plaintiffs in opioid litigation. So I've done a variety of work in the legal setting as well, advising cities and counties and states who are working to recover funds so that they can apply those funds to help prevent further harms from occurring. I trained as an internist in the late 1990s, and I was told at the time, I can remember very well being up late at night in the hospital or sending patients home from the hospital and being taught that if a patient has true pain, you tell me what true pain is, but that if they have true pain, that one need not worry about the addictive potential of opioids. And or the fact that invariably physiologic dependence happens if people take them for more than days to a week or two. And I was part of a whole generation of clinicians that was trained as such. And in fact, nothing could be further from the truth. So there's an enormous amount of evidence, of scientific evidence. This is what I do for my day job, and I can assure you that there's an enormous amount of evidence about the clinical risks of opioids. And you will be hearing from my colleague, Counsel Brennan, regarding rogue prescribers and doctors that are way beyond the norms of modern medicine, and at 5th and Main Street seeing dozens of patients a day, cash only, et cetera. But I'm not here to talk about that dimension of the opioid epidemic. I was trained in a good program, and I'm one of tens of thousands of clinicians, a generation of clinicians that was trained essentially that we were overestimating the risks of opioids. And I can assure you there are dozens and dozens of studies. There are enough studies that they're very good systematic reviews that summarize the evidence regarding the safety of opioids. One of the better ones was done by Voles and colleagues, published in 2015 in a journal called Pain. And they estimate that among individuals taking opioids for chronic non-cancer pain, between 21 and 29% of individuals have non-medical use, what we call misuse, and between 8 to 12% of individuals have experience addiction. And I can assure you that if the rates of harms that we see with opioids were present with virtually any other class of medicine, the medicine wouldn't even be on the market. I mean, if I told you that in your country, in Sweden or France or Portugal or whatever countries you represent, if I told you that 25 people died last year from a diabetes drug, I would bet dollars to donuts that the drug would be pulled from the market. And yet in the United States, we don't have 20 people dying a year. We don't have tenfold that, 200. We don't have 100-fold that, 2,000. We have 1,000-fold that or more. So there are phenomenally high rates of harms from opioids if you consider the extent of the population that's been exposed to the products. Now, there are many myths that have allowed for the epidemic to flourish in the United States, and they're not just around safety. I mean, another one is that opioids are effective for chronic non-cancer pain, when in fact, there's remarkably little evidence demonstrating their effectiveness for the long-term treatment of chronic non-cancer pain. Another is the notion that no dose is too high. You know, we used to think, well, if they're not responding to 40 milligrams, just bump it up to 80. And what we've learned the hard way is that, in fact, you know, that when patients develop tolerance to opioids, they may what we call tachyphylax. They may be tolerant to the analgesic effects of opioids, but the toxicities are dose dependent. And so the likelihood of respiratory depression or other adverse events are dose dependent. Another myth that we can use screening tools to identify who's likely to experience adverse events so that we can sort of sort out the people that are going to be addicted from the people that won't. And that's just pure, you know, BS, to use a technical term. That just isn't true. We don't have screening tools that allow for that sort of separation. Now, a lot of these myths and misconceptions have been driven by industry. And it's you know, it's not an accident that we've ended up in a place where we are. Now we're in a setting where there's enormous litigation taking place. There are many cases being brought against manufacturers, wholesalers, and pharmacies in the United States, and tens of billions of dollars being generated for these communities that have been devastated to try to apply to reduce further harms. And so it's really a unique point in time in the United States and North America, but we're also at a point in time where the opioid industry continues to try, with varying levels of success, to use the same playbook that was used in the United States and in North America in other countries around the world. So I'd like to make one or two final comments. One regarding the continuing very high rates of morbidity and mortality from illicit fentanyl. It is true that most people dying of opioids this year in the United States will die from illicit fentanyls, not from prescription opioids. But what you will hear argued is that since there's been a reduction in prescription opioids by 60, 70%, 65% since the peak in 2010, since we have large reductions in prescription opioid volume and even higher rates of death from illicit fentanyls, what you will hear is that this is a demonstration that the problem really isn't the healthcare system. It's not prescription opioids, because we're 60, 65% down on prescription opioids, and yet more people died last year in the United States than ever before. And this also is just BS. This simply isn't true. So my own work and my own research team and that of many others have done work demonstrating the important lag between when one turns off the spigot of prescription opioids and when you should expect to see the corresponding health gains. If I told you that everybody in Vienna or everybody in Austria quit smoking cigarettes tomorrow, Would we stop seeing emphysema a week from now? You know, would you expect to see reductions in stroke a month from now? I mean, would it even be plausible to say that we're going to see reductions in lung cancer a year from now? Of course not. So there is an important lag, and unfortunately, there's an important lag between when you reduce the population level exposures and when you should expect to see the commensurate health gains. And so there's unfortunately in the United States, we have millions of Americans that have opioid use disorder. And a lot of the morbidity and mortality, a lot of the harms that continue to accrue arise from individuals that have opioid addiction already. So we have an estimated 2 to 2.2 million individuals with active opioid use disorder. Within the past year, they fit the criteria. And another 2 to 3 million with a lifetime history of opioid use disorder. That's 5 million people. I mean, the US is only 330 million. So we're talking about more than 1%, maybe 1.5% of the population that has a history of opioid use disorder. And so my point is that population is a reservoir that contributes to enormous harms going forward. The last comment that I want to make is just about, well, I want to acknowledge that the North American opioid epidemic is complex and multifaceted and dynamic. And, you know, my main hope is that together that we can learn, and our experience in North America can help to inform your own country's experience so that your own country doesn't have to go through the heartache and the social catastrophe and healthcare catastrophe that we have gone through in the United States. And, you know, my final point is this, which is that I want to be very clear that the epidemic is one that's deeply, deeply rooted in the healthcare system in the United States. And by a profound miscalibration on the part of clinicians, on the part of patients, and on the part of policymakers and researchers, such as you and I, regarding the risks and the benefits and the appropriate role of opioids in clinical practice. So thank you again for coming, and I look forward to your questions and comments.
Thank you. Thank you, Dr. Alexander. Next, we're going to hear from Bridget Brennan. And as I mentioned, Bridget Brennan is New York City's special narcotics prosecutor.
Well, good morning, everyone. Thank you so much for joining us today and so early in the morning. I'm the special narcotics prosecutor for New York City, and that means I have the opportunity and the obligation to prosecute high-level narcotics trafficking offenses. And because I'm the head of the agency, I've had a front row seat as we've seen the opioid epidemic unfold across the United States. I've seen it sweep through New York City and the rest of the country. Today's most deadly drug is illegal fentanyl, illicit fentanyl. It's killing record numbers of Americans, reducing our life expectancy. And now we've learned that opioids are the leading cause of poisoning death for children under 5 years old. But I'm here today to describe just how that crisis began. Again, I had a front row seat. The worst drug epidemic in American history began with legal prescription drugs that are highly addictive, were widely overprescribed, and laid the groundwork for the opioid epidemic that we're experiencing today. Now, Dr. Alexander described the limitations of opioids as painkillers, and Dr. Kolodny will detail what happened when powerful pharmaceutical companies promoted these medications and American governmental agencies failed to appropriately regulate them. I will describe how unscrupulous physicians set up practices to provide addictive medications, sometimes with no medical examination, in large quantities, and with no plan to ever taper their patients off or discontinue the pills. Those doctors found it was an easy way to make money. How did I come to this? I started to hear of diversion on the street, that pills, legal pills were being sold on the street. But I also started to hear complaints from parents that they lost their children to addiction. I started to hear from treatment providers that we work with, addiction treatment providers, that they were seeing many people who were experiencing addiction because of these pills, and that they were seeing the people then turn to heroin because heroin was cheaper and gave them a faster high. And as I understood what was going on, I'm a lawyer. I don't have a medical background. I don't know how this works. So I searched, this was about now 13 years ago, for a medical expert who could help me. And that's how I found Dr. Kolodny. I found a YouTube of his talk on the internet, which seemed to intersect with exactly what I was seeing. So I reached out to him and asked him to speak to our attorneys and our investigators. We have a staff of about 200 in my office, to explain to them the dimensions of this problem, because I wanted my office to investigate this as criminal action. Now, in the United States, we don't generally prosecute people for poor prescribing practices, but this was something very, very different. This was doctors who were seeing dozens of patients, hundreds of patients with no medical examinations, no follow-up, no nothing, giving them addictive prescriptions, and the people were dying. Many people were dying. And Dr. Kolodny helped explain to my staff what was happening and helped to educate us. It was a very close partnership, which I think we need if we're going to be tackling these kinds of issues. So what I want to tell you about is just one physician, because I think it exemplifies the kinds of issues that we were facing. That doctor was Dr. Stanley Lee. Dr. Stanley, from 2008 to 2011, during the week, he worked as an anesthesiologist in the hospital. He worked full time. But one day a week, he ran a cash-only pain management clinic in Queens, one of the boroughs of New York. And we got a complaint from a citizen about that. The citizen said that there's a doctor running a practice one day a week, and there are young people lined up outside his door every Saturday, and they look healthy. I don't know what's going on. And we conducted an investigation to try to figure out, we made those same observations, and we used some of the other tools that we have available to us to see that his prescribing was very, very high for a one-day-a-week practice. It was one of the highest that medical experts that we consulted with has seen. And then we started conducting a search among medical examiners and coroners who do reports after people died of sudden unexplained deaths. And we learned that quite a number of his patients had died. In total, at the conclusion of our investigation, we learned that in that 3-year period we were looking at, 16 of his patients had overdosed and died. And you know, that's a pretty high number, especially for the age group he was treating. So, of course, that was only the number who died of overdose. There were other deaths associated, and certainly destroyed lives associated with that practice. There was one former patient who was addicted to an opioid drug, who robbed a pharmacy on a Sunday afternoon to get those drugs. And he killed 4 people in the process, including a 17-year-old cashier who was working there part-time. He was desperate to get the drugs, and he was driven there by his wife, who was also a former patient of Dr. Lee's. And so we see this, exactly this trajectory of how the addiction led to destroyed lives, overdose deaths, and other crimes. And so we've worked closely together with Dr. Kolodny and other health experts on this problem. And there have been advances, but there are some myths that I just want to point out to you. One of the myths, and if you want to just show that first slide, this is what we saw. This is when I started looking at it, was not until about 2010. But this is a slide that shows how the consumption of oxycodone, that reason I take that, because that's the one we saw being sold on the street the most. That's the one that was most often prescribed. Sometimes we're seeing dangerous combinations of prescriptions prescribed. And actually, when they went in to see Dr. Lee, it was not really much of a visit. They were given a number like you get in a bakery, a number, and they were called by the number, not by their name. When they got in there, they were in there long enough for him to write a prescription and for them to give him cash, and then they were out. So he would literally see 100 patients on a Saturday. But in any event, the next slide, please. So this is the oxycodone. You can see how the trajectory of the prescriptions filled increased. And when I was looking at it was 2010. It hadn't quite peaked yet, but it certainly come near its peak. And it then tapered off as the state did and the federal government did start to finally regulate these drugs and people became aware of their problems. Next slide, please. But look at where we are in 2010 first, in 2011, 2012. Next slide, please. So this is a graph of the illegal drugs. This is our seizures of fentanyl, heroin mixtures from 2016 to, actually it's from 2010 to 2022. And that top line is heroin. That's the drug we started to see come in right in back of the oxycodone, the prescription pills. They're developed a very large illegal market for drugs, and people, these are our major seizures. On the left are the pounds of drugs we were seizing in a single year. And if you look at this trajectory of the heroin seizures, the yellow line, you see that the heroin seizures were peaking and beginning to peak at the same time the oxycodone prescriptions were peaking. So one didn't replace the other. The heroin didn't replace the oxycodone. They're going up at the same time. And then the fentanyl came in. The fentanyl is the orange line, and the mixtures are the orange and the lighter orange line. Now, fentanyl, the seizures are lower because that's an extremely potent drug. So you don't need as much of it both to get high or to kill people. And so that's what followed the heroin. And now in New York, it has really just replaced heroin and it's killing lots and lots of people. We've had a record number of overdose deaths in New York City. So that's why I'm here today. I just want you to know that certainly this can happen in any country, anywhere. No one's immune from this because, as Dr. Alexander explained, there's a physical relationship between the patient and this kind of drug. And so if these drugs get out of control, it lays the foundation for illegal drugs to come in, which is happening across the United States. And don't think that the US and Canada are the only countries that can be affected by fentanyl. Fentanyl is made from synthetic components, can be produced anywhere. In Mexico, it's being produced often grazing lands, in makeshift labs under conditions with no quality control, of course. And so it can be produced anywhere and can happen to any country. And I would hate to see this kind of thing happen anywhere else. We're trying desperately to rein it in the United States. So thank you for your interest, and I wish you all the best, and thank you for your attention.
Thank you. And just before I begin, I just want to point out that what we heard from Dr. Alexander was the way in which many well-intended physicians inadvertently harmed their patients, created cases of opioid use disorder, iatrogenic opioid use disorder, and also created opioid use disorder by stocking medicine chests with this highly addictive drug. The pill mill doctors, the drug dealing doctors that Bridget Brennan has worked to to prosecute. These were doctors who were really profiteering, really exploiting individuals with opioid use disorder. And in many ways, it was the well-intended doctors that created the epidemic of opioid use disorder. The mortality has been driven by many of the pill mill doctors and black market opioids in recent years. So let me get started. I'd like to just begin with framing the opioid crisis in the United States. These are different headlines that have appeared in U.S. newspapers in the past couple of years. And we talk about the opioid crisis frequently in the U.S. and hopefully it's getting national attention. But how should we frame the problem? How should we understand what's driving it? I think the correct way to understand this is as an epidemic of opioid use disorder. When we frame it that way, it means that the reason we've seen fentanyl flood into the United States, the reason we're experiencing record high levels of opioid-related overdose deaths, the reason we've seen a soaring increase in infants born opioid dependent, outbreaks of injection-related infectious diseases, impact on the workforce. The driver behind all of these health and social problems has been a very sharp increase in the prevalence of opioid use disorder. In the United States today, about 4 to 5% of the adult US population may be suffering from opioid use disorder. That's a very large number of Americans. To make sense of the mortality statistics that you may come across, we heard there were 100,000 drug overdose deaths in the United States in 2022. To make sense of the mortality, it's important to understand the epidemiology. Roughly, we have 3 groups of Americans suffering from opioid use disorder. The first 2 groups on this slide are individuals who developed their opioid use disorder from prescription opioids. It's a younger group that became addicted to prescription opioids and then switched to the black market, and an older group that really hasn't switched that much and has really continued to overdose from prescription opioids. The third group are really survivors from the heroin epidemic of the 1970s that bled a little bit into the 1980s. That the first 2 groups are disproportionately white and suburban and rural. The third group is disproportionately non-white and urban. These are individuals who developed their opioid use disorder in their teen years from heroin use. I mentioned that the right way to frame the opioid crisis is an epidemic, is as an epidemic of opioid use disorder. I'm going to show you that happening. The epidemic began in the year 1996. This is 3 years into the epidemic. The states that show up as red or maroon are the states that have the highest rate of individuals seeking treatment for addiction to prescription opioids. And what I'd like you to see is what happens to the color of the map as we go forward. So this is 2-year increments. And by 2001, you'll see many more states had turned red or maroon. 2003, 2005, 2007, and 2009. By 2009, just about every state in the United States had seen a very sharp increase in the prevalence, the number of people suffering from the condition of opioid use disorder. Why did the map turn red? Well, I think the first and best answer to that question came from the CDC. This was a graph that the CDC created. And what they're showing us with this graph is that as sales increased in the United States for opioids, deaths increased directly in parallel with the increase in sales. This is another slide from the CDC. And on this slide, the green line represents prescriptions for opioids or opioid consumption. The red line represents deaths involving prescription opioids, and the blue line represents opioid use disorder. And what you can see is that as the prescribing went up, it led to parallel increases in rates of addiction and overdose deaths. What drove this very sharp increase in opioid prescribing that would lead to this epidemic was a multifaceted campaign that changed the way the medical community thought about opioids. The risks were minimized, the benefits were exaggerated. That very campaign that influenced the medical community in the United States and regulators in the United States has been launched internationally. And one of the countries that was central to this in the United States, Purdue, which in many other countries goes by the name Mundi Pharma, has worked very hard to influence the international community. And in many countries across the globe, we are seeing opioid prescribing increase because of the use of the same playbook that worked so well in the United States. A playbook that involves using influential clinicians, involves using pain organizations that in effect are front groups for industry that promote very aggressive prescribing and downplay the risks of opioids. And this slide that you're looking at comes from a report and investigation, a bipartisan investigation that was done by 2 members of Congress in the United States to look at the way in which the World Health Organization was influenced. Their investigation led WHO to remove 2 guidelines that had misinformation about opioids in them. Opioid consumption, as I mentioned, is increasing in many countries. The top line here is the United States, but we have seen many other countries are beginning to follow in our footsteps. These countries include the Netherlands, Sweden, Switzerland, France, the UK, Australia, and many other nations. And I'm just mentioning the countries where reports have been published showing the increase in prescribing and the increase in opioid-related harms. Certainly this phenomenon is occurring in countries that have not reported this data. Very often we hear advocates for increasing opioid prescribing talk about the need for balance. This is a slide that was shown at a meeting in the United States at the Food and Drug Administration. It was shown by a pain organization funded by Purdue Pharma. And the idea behind this slide, the message that was communicated to the FDA, was that if the FDA were to put a drug called hydrocodone in a more restrictive category, that it would be punishing this pain patient for this abuse by these teenagers in this photo. The idea was that policymakers need to be balanced. Don't harm the pain patients in your effort to deal with misuse. This is a false way to frame the problem. We don't have these 2 distinct populations of so-called drug abusers where the harms are limited to the drug abusers and pain patients who are claimed to be helped by opioids. There is a tremendous amount of overlap. In the United States, individuals with chronic pain have been disproportionately harmed by the increases in prescribing. We've seen 35% of individuals on chronic opioids meeting criteria for opioid use disorder. In a study of prescription opioid overdose decedents, 92% of the decedents were receiving opioid prescriptions for a diagnosis of chronic pain. In summary, the United States is in the midst of a severe epidemic of opioid use disorder and overdose deaths caused by an oversupply of prescription opioids. This phenomenon is repeating itself in other nations. We must think about balance differently. Too often the idea of balance is promoted as if all harms stem from diversion and abuse. We must recognize that harms can also result from medical use. Regulators and clinicians really do need to balance the risks versus benefits better. To do that, they need to understand the risks. They need to understand that, especially with long-term use, effectiveness really isn't there. In fact, with long-term use of opioids, we can even see pain worsen. It's a phenomenon called hyperalgesia. And lastly, regulators really do need to appropriately balance risk versus benefit for their societies. Thank you. So in the remaining time, we would like to take any questions that you have or maybe explain a little bit more of what we've covered. Yes.
Hi, I'm Dr. Adnoff. I'm here with doctors. I'm president of Doctors for Cannabis Regulation. First, Dr. Alexander, I just want to mention, you mentioned that in the 90s, you were trained in the way you've talked about. And so there's a generation of physicians. I was trained in the 70s, so you can make that 2 generations of physicians were trained in exactly the same erroneous way. The focus of the panel has been on the opioid use disorder and the fentanyl deaths. And we hear so much about accidental overdose, that fentanyl has infiltrated the all drugs, illicit drugs now. And in fact, I'm in Colorado where we're trying to, they changed the law so that even a detectable trace of fentanyl results in a felony now. Could you comment on the role of the accidental overdose, the infiltration of fentanyl into the system outside of it being an issue with opioid use disorder?
Sure, I'll be happy to, and thank you for that. And I imagine, excuse me, both of my co-panelists may wish to comment as well. You're right. You're right. And as fentanyl has become, illicit fentanyl has become more common and more abundant, one of the consequences that we've seen are more accidental overdoses. We published a paper about a year or 2 ago looking at seizure records where we found the combined presence of fentanyl with, for example, methamphetamine or with cocaine has increased a lot over time. The sort of data that's required to understand is that accidental or not, and what is known to the end user is not data that typically is not data that is that I typically use or that I'm most familiar with. And so I would ask maybe one or both of my co-panelists, but my sort of high level read of the evidence is that both accidental poisonings are absolutely happening. I mean, we hear about, 4 college kids found dead. They thought they were using cocaine. It turned out that it was cocaine and fentanyl. But I think that there also is combined use that's known to the end users as well. So I'll see what Dr. Kolodny or Council Brennan want to say.
Sure, and Dr. Bridget Brennan can also comment a little bit more about fentanyl found in various drug samples, but just a little bit on terminology. When we talk about an accidental overdose, that's in contrast to a suicide, which would be an intentional overdose. So when we talk about 100,000 overdose deaths in the United States every year, these are accidental overdoses. And what we know from studies of overdose decedents is that the vast majority of decedents were individuals with opioid use disorder. Certainly, there are overdoses occurring in individuals who did not have a substance use disorder, but may have been experimenting. And we've seen particularly in teenagers, we've seen a very sharp increase in the past few years of fentanyl overdoses in many teenagers who were likely did not have opioid use disorder. Despite that very large increase, when we talk about 100,000 deaths in the United States, only about 1,000 were in these teenagers, 99,000 were in adults. The vast majority were opioid. And again, the vast majority are in individuals suffering from a preventable, treatable condition, which is what we're talking about when we say opioid use disorder. Before I turn it over to Bridget, I just want to point out that on this slide, I mentioned the 3 populations, the 3 groups that are suffering from opioid use disorder. Fentanyl has resulted in a soaring increase in overdose deaths in group number 1 on this slide and group number 3. It's the group that had really wound up on the black market. So it's in these younger, not so young anymore, white individuals who became addicted through prescription opioids, and in older, largely Black men in Baltimore, North Philly, South Bronx, and in cities that had been hit very hard with heroin. These are men who managed to beat the odds for 40 or 50 years despite their opioid use disorder. But with fentanyl in the supply, they're losing their lives at a very high rate.
And just to reinforce that, that's what we see in New York. The highest rates of overdose deaths are in communities of color. Highest rate is among Blacks now, and impoverished communities. But going back to your original question, in terms of the drugs that we seize in our cases, we get lab reports back from we work with the DEA or the New York City Police Department. And the cases that we work with the police department generally involve cases of street sales or lower level use or selling. And we see tremendous mixing of drugs. We get very little heroin now, although the drug might be sold as heroin. It is almost always fentanyl, and it's rarely just fentanyl. Often the fentanyl is mixed with other dilutants. It might be tramadol for whatever reason. We've seen it mixed most recently with an animal tranquilizer, which isn't intended for human use, called xylazine. We're seeing it mixed with other things, but we're also seeing fentanyl mixed in with cocaine, and people thinking they're buying cocaine are getting fentanyl, and sometimes it's fentanyl and xylazine. And so we just see a tremendous number of mixtures. Often people who are buying the drugs have no idea what they're getting. We're also seeing a lot of pre-pressed pills coming. They are all mostly originating in Mexico, and they're coming already to the United States through New York, pre-pressed. Some of them might be made to look like Adderall, which is a common stimulant drug, or made to look like oxycodone, or all kinds of different drugs. So they may be, in a sense, counterfeit. Some of them may be just rainbow drugs that kind of look like ecstasy. But we're seeing a lot of that. What we're seeing with fentanyl is that it's constantly shape-shifting. It is being mixed up with all kinds of new things all the time. And it is being sold in different forms all the time. And one of the worst things about the mixes is, for example, we educate people about Narcan, which can revive you if you are overdosing from an opioid. However, xylazine is not responsive to Narcan. And so if you get one of these mixes that has xylazine as well as fentanyl, the Narcan will not revive you. Or if you get cocaine, in fact, bars now in New York, the bartenders often have Narcan on hand, because people who are coming to the bar and buy some cocaine there and use it there may get fentanyl. And so they use Narcan to revive them. But if it's mixed in with xylazine, it's not going to work. So we're seeing this constant mixture, which is just very discouraging and leading to increased deaths. Thank you.
Thank you.
Hello, I'm Julian. I'm from Canada, so similar system to the US. And I was curious in terms of your prescription monitoring program and your regulating of physicians, since it's a problem that's so deeply rooted in the healthcare system. What successes or what aspects of those two parts have you found to be useful to help address this issue?
Yeah, I appreciate the question, because the statistics, the mortality statistics are so depressing. What might we be doing that's working? Where might there be light at the end of the tunnel? There is some data out there that can give us a sense of hope. So when we look at rates of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, infants who are born opioid dependent, what we saw in the United States following the soaring increase in prescribing, we saw really a soaring increase in infants born opioid dependent. Opioid prescribing in the United States peaked around 2012 and has gradually come down since. We are still massively over prescribing. We continue to prescribe more than any other nation. What we started to see a few years after the prescribing went down, about 2 or 3 years, we began to see decreases in infants born with neonatal opioid withdrawal syndrome. So that condition really peaks around 2016, 2017, and has been coming down since. A few weeks ago, I was in the state of Alabama, in a region of the state hit very hard by the opioid crisis. I was meeting with a nurse who works with infants who are born dependent on opioids. And she was explaining that a few years ago, we were treating 5 infants a week. Now we're down to 1 infant a week. So with more cautious prescribing, there is evidence that the incidence, the number of Americans becoming newly addicted is decreasing. Because we continue to overprescribe, there are still too many Americans becoming newly addicted, but at least that trend is moving in the right direction. Any other questions? If not, I do have one final point that I'd like to make, which is a lesson from the North American opioid crisis that I don't think gets enough attention. And I did start by talking about this tension between those who advocate for demand reduction and those who advocate for supply control measures. One of the lessons of the North American opioid crisis is really how supply and demand are interrelated. We wound up with an epidemic of opioid use disorder driven by a massive oversupply of legal prescription opioids. Once we wound up with an epidemic of opioid use disorder, that resulted in tremendous increases in demand for illicit opioids. And what we've seen is fentanyl flood into the United States to meet demand. What this really tells us is that the two are interrelated. It is not an either or. If we're going to address drug problems or prevent them, we have to consider both supply and demand. Oh, and by the way, as a thank you for attending the side event, if you have not already taken a copy of DopeSick, we have copies here. And this DopeSick is a Hulu series. I don't know if it's available outside of the United States. It's a TV series focused on the opioid crisis in the United States, in particular, one drug company, Purdue, but keep in mind that many other pharmaceutical companies in the US and internationally have been really using the same playbook. So thank you. If you didn't sign in, please sign the sign-in sheet before.